This is a continuation of Chapter 4, the Integumentary System. This is the second PowerPoint, or second recording for the same PowerPoint, and we are picking up with the accessory structures of the skin, starting with the hair. Hair is also known as pili. It will be present on most of your skin surfaces except for the palms, palmar surfaces of the digits, the soles, and the plantar surfaces of the digits. So this is also known as your thick skin. So it is not present on thick skin, but it is present on thin skin. It's going to be composed of dead keratinized epidermal cells, and you have genetic and hormonal influences that can determine the thickness and the distribution of hair. The functions of your hair include protection. They'll help to also decrease heat loss and in sensing light. The parts of the hair include the shaft, the root, and the follicle, which then has an external root sheath and an internal root sheath. The shaft will be above the surface, whereas the root will penetrate the dermis and the subcutaneous layer to go below. You have 3 concentric layers of cells that are going to go along that entire root and shaft, and those are going to be the medulla, the cortex, and the cuticle. The medulla could possibly be lacking in the hair is thin, and it generally has 2 to 3 rows of irregularly shaped cells that contain large amounts of pigment granules. The cortex is going to form the major part of the shaft and be the elongated cells. And then the cuticle will be the outermost layer, and it's a single layer of thin, flat cells that are the most heavily keratinized. The external root sheath is a downward continuation of the epidermis, and the internal root sheath is going to be produced by the matrix. So our hair matrix cells will arise from the stratum basale of your epidermis, and the new hairs will develop from cell division of the matrix within a portion of the hair called the bulb. At the base of each hair follicle, it's going to be surrounded by the dermal root sheath, and that's going to be an onion-shaped structure. Now, with hair, we also associate our sebaceous or our oil glands and our erector pili muscles and root plexuses. With hair, you can remove hair many different ways, but 2 that we'll talk about here clinically would be depilatories and electrolysis. With depilatories, those are the creams and the products like Nair. Those will go and dissolve the protein that's actually within the hair shaft so as to remove it, whereas electrolysis uses an electrical current to destroy the hair matrix. So our hair growth, our hair type, and our hair color are what we'll discuss on this slide. So our hair is in a growth cycle. So it's a continuous process of growing, regression, and resting. We spend the vast majority of that time in the growth stage, especially with the hair that comes out of our head, and then it will regress. When it regresses, the follicle atrophies and gets smaller and shrinks, and then it will rest and not be going through any type of mitosis or actual growth process. So the rate of growth and the rate of replacement here, those things can be altered by our illness, by diet, high fevers, surgery, blood loss, also by severe emotional stress, and also can be based on gender. Chemotherapy is going to be something that can result in hair loss because chemotherapy itself seeks out cells that are actually growing and dividing, or cells that are in the growth phase. So when people lose their hair during chemo, or a lot of their hair during chemo, that means that a lot of their hair is in that growth phase typically. And then we also have alopecia, which is the thinning or the loss of hair. Now, types of hair. We have lanugo hair, which will cover the fetus. So that's just a fetal, fine, non-pigmented hair. And then after birth, we have the vellus hair that will be short, fine, pale hairs. So these vellus hairs will be present, like we said, immediately after birth, but then they also will stick around sometimes on the face, can be covering a lot of the surface of other places. So if you are in tune with new procedures for skincare, I'm drawing a blank now, but the facial procedure where they actually go in and take a small little layer of your hair and the first layer of skin off, that is actually going to be where they're removing the vellus hairs. If I think of it while we're in this video, I'll be sure to mention it again, but if I don't, I will post it below in the comments. But that's removing the vellus hairs. And then once the hair becomes more coarse, it will be what we call terminal hair. So those hairs are longer, more coarse, and they have much more pigmentation to it. These can also come in response to androgens or hormones. So a lot of times that's why you see men having more thick, coarse hair. So the androgens are generally your testosterone hormone. Hair color. So the color of our hair is going to be primarily due to the amount and the type of melanin that's present. And then when our hair begins to gray, it's because of a progressive decline in tyronase, which is one of the enzymes that is responsible for melanin. Glands of the skin. So we have four main types of glands: sebaceous glands, and then we have eccrine and apocrine glands, as well as ceremonous glands. So sebaceous or oil glands, those are usually going to be actually connected to the hair follicle. So those glands will be connected to the hair follicle, and the clinical connection here, those glands will secrete what we call a sebum. That sebum will moisten the hair, give it a waterproofness, help to soften the skin, and it'll also help to inhibit bacterial growth. However, if that gland becomes inflamed, the result there is acne. The sudoriferous glands, or your sweat glands, we divide those into the eccrine and the apocrine. So the eccrine sweat glands, they have an extensive distribution, so there are many more of them throughout the body or throughout, and their ducts are going to terminate at pores at the surface of the epidermis. So they're at the surface of the epidermis so that they can exit. So E for epidermis, E for exit, the eccrine or the eccrine sweat glands. And then the apocrine sweat glands are going to open into actual hair follicles. And they'll open into the hair follicles. Their main function is to help regulate body temperature through evaporation. They'll also help to eliminate waste such as urea, but that's a secondary function. So their main function is to help get rid of or help regulate your temperature through evaporation, and then they'll also help get rid of some waste products. Sorry, that's the eccrine glands. The eccrine sweat glands, those are the ones that are helping to regulate your body temperature and get rid of waste. The apocrine sweat glands, those are a little bit more limited, and so they are found in the skin of the axilla, the pubis, and the areola. Their ducts open into hair follicles. And so we have a table that will also show us a comparison on the next slide. Finally, the ceremonous glands, these produce what we call cerumen, which is a waxy substance, and you will find this in the external auditory meatus. And so that is going to be your earwax. If you have impacted cerumen, that means you have an abnormal amount of cerumen in the external auditory meatus or in the canal, and unfortunately it can, because wax is a sticky like substance, it can become hard in there, become impacted or stuck, and then it will prevent the sound waves from actually reaching your eardrum, and you won't be able to hear. So here's this nice table that summarizes the glands. Nails. So our nails are going to be a hard keratinized epidermal layer of cells over the dorsal surface of the terminal portion of your fingers and your toes. The principal structures of the nail are the free edge, the body, the root, the epicynum, matrix, and the laluna. Our cells are going to divide at the matrix to produce new cells, and functionally our nails help us to grasp things and manipulate small objects in various ways, and they can also provide some protection against trauma to the end of your digits. So here you just see a more detailed image going into our nail matrix, where we actually have the dividing cells giving you new nail cells. The nail root, this portion is not actually visible. The epicynum, that's your cuticle. It's going to actually be the stratum corneum layer. The lunula is the thickest part, or the white little moon shape, crescent part shape of the nail. And then we have the nail bed below the surface here, and the nail body above, that's the visible part with the free edge. And then right where the nail body meets the nail bed, that is your hypocynum. So now our skin. What exactly are the functions? We've kind of briefly touched on them and gone over, but let's go a little bit more into detail. Thermoregulation, so our skin allows us to sweat through those glands, and it also allows blood to flow through the dermis, and that helps us to regulate our temperature. The dermis has many blood vessels, and so it can hold or actually keep a reserve of blood, about 8 to 10% of our total blood flow while we're at rest. Protection will be the next function. So we're able to protect everything that's underneath the skin, but the protection is provided by that keratin. Remember, we said the keratin provides a hard layer. The lipids that are released by the lamellar granules, because lipids do not allow, fatty substances don't allow watery substances to pass, so that's a protection mechanism. The sebum, we said that sebum can actually get rid of bacteria. Our sweat can be acidic, and so it gets excreted through our bodies. And then melanin is actually going to help to protect us from the harmful damaging rays of the sun, or the UV rays. And then the macrophages that are in our skin can give us protection from any foreign invaders. Now, the cutaneous sensations of the skin, we have different types of sensory receptors found at different layers. So we have tactile sensations for touch, pressure, vibration, and tickle. We have thermal sensations of warm and cool, and then of course we can feel pain. our excretion and absorption through the skin, so we're able to eliminate some of the substances from the body from those glands. And then we can actually absorb some things as well. So the passage of materials from outside to inside. So here is where transdermal drug administration can be good. So they'll have a patch, or they'll apply a cream. It will then move through the skin, and it can then be absorbed from the epidermis to the dermis, where it gets into the bloodstream and can be transported through your body. And then synthesis of vitamin D, D as in dog. So we use these ultraviolet rays that come from the sun. They're a precursor to the molecule calcitrol, and that's what allows vitamin D to be made. So the vitamin D aids in absorption of calcium from foods in our gastrointestinal tract. Okay, so how do we repair wounds? We'll talk about wound healing, whether it's an epidermal wound or whether it's a deep wound. So an epidermal wound will not be very deep. That will be where the central portion of the wound, it is generally a little deeper down into the dermis, but the edges of the wound itself are generally only superficial, only involving epidermal cells. So therefore, if we repair the epidermal cells and wall that off, then everything else can be repaired later. So in epidermal wound healing, we'll have enlargement and migration of the basal cells. And then we have contact inhibition occur. And finally, we have more basal cells to divide and migrate and some stationary basal cells. Those basal cells, remember, are able to actually create new cells. They are still germinating, they are still growing, so those can help the wound to heal. You also need epidermal growth factor. This is going to stimulate those basal cells to be able to divide and replace the ones that have moved into the wound. In deep wound healing, there are 4 phases. This is when the injury extends deeper into deep to the epidermis. It is going to be a more complex process than the epidermal healing, and we generally will end up with scars resulting, or a scar forming. Remember, we said the formation of a scar is fibrosis. So, during the inflammatory phase, you'll have a blood clot begin to actually unite the edges of the wound, and then those epithelial cells will migrate across the wound. And once they do, vasodilation, or a widening of the blood vessel, will occur. It's going to increase the permeability of blood vessels and actually bring more blood to the site, so it will deliver phagocytes. Those phagocytes are basically going to engulf any particles that are there and try and clear out the debris. And then it's also going to have fibroblasts begin to form. So remember, fibroblast, any blast type cell, is an immature cell. So we are beginning a process so that we can create a more mature and a healed environment. In the migratory phase, the epithelial cells beneath the scab start to bridge the wound together. Those fibroblasts begin to form the scar tissue, and the damaged blood vessels itself begin to grow. During this phase, we get the tissue filling the wound, and that's what we call that granulation tissue. In the proliferative phase, we basically just have more of the migratory phase events going on. They begin to intensify. And then finally, in the maturation phase, our scab will slough off. The epidermis will be restored to a normal thickness, and we'll have collagen fibers become more organized. Fibroblasts begin to disappear, and blood vessels will restore to normal. What happens as you age with the skin? So first, age-related or associated change would be during puberty. And during puberty, many adolescents will develop acne, where that sebaceous, those glands become inflamed. Now, most of the age-related associated changes that we see with the integumentary system will actually begin to occur around the late 40s, give or take. And so with these, we'll see wrinkling, slower growth of the hair and the nails, dryness and cracking because your sebaceous glands begin to atrophy, decrease in the number of melanocytes causing your gray hair or even some blotching to the hair. The Langerhans cells, or those macrophages, they are also going to decrease in number, so your immune responsiveness is slower. And you also lose some subcutaneous fat, so it makes your skin thinner. But there are several cosmetic anti-aging treatments that are out there to help diminish the effects of aging, or they can help to diminish the effects of sun-damaged skin. So there are topical products that might bleach the skin to help with the blotches and blemishes, or to decrease the fine wrinkles and roughness, such as your retinoic acids or your vitamin A derivatives. Microdermabrasion, which uses small little crystals and a vacuum to remove the skin's surface cells and help with texture and blemishes. And chemical peels, which actually are going to be a mild acid, such as your glycolic acid, salicylic acid, lactic acid. Those will remove surface cells to help with the texture and blemishes as well. And then there's laser resurfacing. The laser will clear up the blood vessels that are nearest the surface of the skin. And then what you have heard about also, the fillers, where people are actually injecting collagen. This collagen comes from the cows. They inject it in to fill the skin. And then you can also transplant fat from one part of the body into another part of the body. The ever so famous Botox. Botox is actually a derivative of very diluted version of botulinum toxin, and it's injected into the skin. It paralyzes the skeletal muscles that cause your skin to wrinkle. So dermal fillers go in and try to fill those lines and wrinkles, whereas Botox paralyzes the muscles so that the skin won't wrinkle. And then they also have things such as a radiofrequency non-surgical facelift, where the radiofrequency emissions will tighten the deeper layers of the skin. And then there are also invasive surgeries such as facelifts, brow lifts, neck lifts, and all those great things that take the loose skin and fat, remove it surgically. Alright, so we do have, as we move into these actual systems, individually in class, we'll get to have more clinical connections and get into some disease processes. So the first here is going to be skin cancer. There are 3 major types, with 2 of them being non-melanomas and 1 being an actual melanoma. So the first 2, your non-melanomas, are your basal cell carcinoma and your squamous cell carcinoma. The basal cell carcinoma is actually the most common, and then next would be the squamous cell carcinoma. So thankfully, malignant melanomas are very rare in the types of skin cancer. The basal cell carcinoma affects the stratum basale and has a low rate of metastasis. The squamous cell carcinoma affects the stratum spinosum, and its rate of metastasis is variable. So when we say variable, that means it's a little higher than low, but it's still just kind of depends. Melanoma, the malignant melanoma, so it is malignant, meaning that it will metastasize. So it has a high rate of metastasis, and you find this in the melanocytes. So here you see the malignant melanoma. These melanomas oftentimes will develop from a mole. So when the mole begins to become irregularly shaped, you want to think about some things, or if it grows in size, you see changes to it, then you want to get that checked out. So risk factors for skin cancer can be skin type, sun exposure, family history, age, and whether or not your immune system is impacted or weakened in some way by another maybe disease process. And now burns. So anytime your tissues experience damage from excessive heat, electricity, radioactivity, or corrosive chemical, and the proteins become denatured or destroyed, then those exposed cells, then we have a burn. So we have 3 different types of burns. We classify them based on the depth and the damage going on. First degree burn will damage the epidermis, whereas second degree burn damages the epidermis and the dermis, and then the third degree burn is going to be a full thickness and go all the way through both layers of true skin and through the subcutaneous layer. So generally speaking, the effects of burn, the systemic effects are much worse than the local effects, because with those systemic effects, we get to where we're damaging blood vessels, damaging nerve, and then as you see the subcutaneous layer, if it gets burned through, we're actually then allowing organs and tissue spaces to be open to the outside. So you'll lose a lot of fluid, you won't be able to regulate that, and so oftentimes those systemic effects are a lot worse. The rule of 9s is used to grade the severity, measure the severity of burn victims. And so with this rule of 9s, you can see here the breakdown of an adult, and then we also give some percents for children, but you can see the breakdown of if certain areas of the body are affected, then how much of the body or burn area or surface area is affected. When the burn area exceeds over 70% of the body, generally half of those victims will die. And our last and final clinical connection concern is going to be pressure ulcers. These are also known as decubitus ulcers or bed sores. So they'll be caused by a constant deficiency of blood to the tissues. Generally, it's going to be on a bony projection, and you've had prolonged pressure there against the object, so it can be pressure from the bed, hence a bed sore, or these can even occur when a person is in a cast or a splint. And so because you've had this prolonged pressure and deficiency of blood supply to the tissue becomes ulcerated, as you'll see here. So there'll be a little bit of a discussion question and some things to go for this chapter as well. And that is the end of this recording.